Because carbon dioxide is such an important byproduct of metabolism and its release from the body, the measurement of carbon dioxide tension in expired gas is a major component of anesthesia and critical care practice, and we can learn a lot of information from it. This is the first tutorial of 2 on end-tidal CO2 analysis. This looks at capnometry, that's a numerical value of the carbon dioxide in expired gas. Fundamentals of Anesthesiology and Critical Care with me, Pat Nelligan. Monitoring gases and vapors. We've moved on to monitoring carbon dioxide. Part 1, capnometry. Welcome back. In the previous tutorial, we discussed how oxygen is measured on a blood gas machine, and I explained how the Clark electrode measures the PaO2. We then discussed how SaO2, that's oxyhemoglobin saturation, used to be calculated using the oxyhemoglobin dissociation curve on blood gas machines, but these days co-oximetry is used with the added value that it also measures carboxyhemoglobin and methemoglobin. This time, we're going to talk about how carbon dioxide is measured in expired gas, the end-tidal CO2, capnometry, how it's performed, and what it means. Let's start with a look at carbon dioxide in the airway. CO2 gas is produced in mitochondria. It diffuses along a partial pressure gradient into the cytoplasm, the interstitium, venous blood, and alveoli. It's transported in the blood in the dissolved form, combined with hemoglobin, and as bicarbonate. It is removed by the body by tidal ventilation. And these are the standard values of carbon dioxide. Approximately 200 mils of carbon dioxide are manufactured by the body within the mitochondria as a component of the Krebs cycle every minute, and the same amount of carbon dioxide is eliminated from the body through the lungs. The partial pressure of CO2 in venous blood is about 46 millimeters of mercury or 6.1 kilopascals. Alveolar CO2 is approximately 40 millimeters of mercury or 5.3 kilopascals, and that equalizes with arterial blood where the partial pressure is 40 millimeters of mercury or 5.3 kilopascals. In hypermetabolic states, we generate a lot more carbon dioxide, but we also eliminate a lot more carbon dioxide. And guess what? Although the partial pressure of CO2 may or may not rise in venous blood, the alveolar CO2 and the arterial CO2 remain more or less the same. The total alveolar ventilation increases substantially nevertheless. At the end of inspiration, just prior to exhalation, having inhaled air that contains essentially no carbon dioxide, there is a 20% increase in alveolar volume, and as a consequence, the partial pressure of CO2 in alveolar gas drops to about 32 millimeters of mercury or 4.2 kilopascals. Carbon dioxide and oxygen are continuously entering and leaving the alveoli, and the partial pressure of CO2 in the alveoli rapidly equalizes with that of arterial blood. CO2 then slowly diffuses into the anatomical dead space. During early expiration, that CO2 that has diffused into the anatomical dead space is the first to be released from the airways, but it is dilute, only 2% of expired gas. So the early expired partial pressure of CO2 is maybe 2 kilopascals or 15 millimeters of mercury. By the time end expiration is reached, the true alveolar CO2 content is now being expressed out of the lungs, and the partial pressure of that gas is marginally lower than the PaCO2. That value, the partial pressure of CO2 in end expiratory gas, is known as the end tidal, as in tidal volume, CO2. So let's put all of this together. We are at that point just prior to exhalation. Remember, the majority of the CO2 is in the alveoli, and it represents about 5% of alveolar gas. As we work our way through the airways, the CO2 is 4%, 3%, 2%, 1%, and in the mouth there is no CO2 at all. If we look at the different components of the airway, we have the upper airway, the anatomical dead space, the trachea and the bronchi, and the alveoli. As expiration proceeds, the upper airway and dead space CO2 is released first. Then the CO2 increases progressively until there is a plateau. The point of maximum CO2 release is at end expiration, and this is the end tidal CO2. If we change our y-axis to partial pressures, the normal partial pressure of CO2 at end exhalation, the end tidal CO2, is 5.1 kilopascals or 38 millimeters of mercury. Remember that in reality, exhalation is very fast, so the upstroke from zero to the initial arrival of CO2 from the alveoli is very rapid. Nevertheless, full equalization does not occur until the very end of expiration, so this is the normal capnograph trace. Note the long chunk of CO2 is there because it represents the alveoli, and that is where the CO2 is. Now, let's move on to capnometry. You are called to a cardiac arrest. Sam is 72 years old and he arrested on the ward. Just as you arrive, a doctor is in the process of intubating the patient. The tube is placed and the doctor is confident. There is bilateral chest movement, bilateral breath sounds. The endotracheal tube mists up with water vapor. So the tube is in the lungs, right? Maybe, but maybe not. It is an absolute standard of care in this setting to identify carbon dioxide in expired gas. A little known fact is that air that is located in the lungs and air that is located in the stomach have a similar percentage of carbon dioxide. There is quite a lot of air in the stomach as we swallow air all the time, and CO2 is produced by various means by the gastric mucosa. The difference is that when we insufflate the lungs, the gas that goes in is immediately replaced by gas that comes out. And the bag refills if you're using a refillable anesthesia bag. That is not the case with an ambibag, so you need to be very careful with ambibags. Gas that is delivered to the stomach, for example, by an esophageal intubation, passes along the lowest pressure gradient through the bowel, usually. When we are placing an endotracheal tube, it must be inserted into the airway and not into the esophagus, and we confirm placement by measuring carbon dioxide in exhaled gas. This is a calorimetric CO2 detector built into a heat and moisture exchanger. The key element here is a piece of paper that is like litmus paper that interacts chemically with CO2 and changes color. You can see the percentage CO2 is related to the color change. This gold color is equivalent to 5% CO2. The bronze color is about 2%, and the purple color, the resting state, means pretty much no carbon dioxide. In this cartoon, we have just intubated the patient, and we've attached the end of the tidal CO2 indicator to the endotracheal tube and on the other side to an anesthesia breathing system or ambibag. The device starts with a purple color. If the color changes from purple to gold, it is G for go. The device is somewhere in the airway. Remember, The gold color is approximately 5% carbon dioxide. When you bag the patient to deliver an inspiration and then the bag refills, if gas passes through the indicator and it does not turn gold, it remains purple, that means that the tube is not in the airway, it's likely in the esophagus. Just because you get CO2 back does not mean that you have successfully intubated the patient. It just means that the tube is not in the esophagus. The tube can be in the pharynx, it can be in the glottis, it can be where you want it in the trachea, or it can be in the bronchus. The presence of CO2 confirms that the airway device is in some part of the airway. It does not confirm intubation. Confirming intubation is quite controversial. In my view, the only way to truly confirm intubation is to put a fiber optic scope down through the tube and see the carina. For most of us, most of the time, there is a degree of clinical judgment. There should be no leak once the cuff is inflated. Inspired and expired tidal volumes should be more or less equal. Inspired tidal volume is always slightly greater than expired because the lungs take up a little bit more oxygen than they release CO2. The partial pressure of CO2 in expired gas, the end tidal CO2, should be above 1.5 kilopascals or 10 millimeters of mercury, and it should be consistent and not variable. When we previously looked at light absorption along the spectrum of ultraviolet to visible to infrared, we focused on the absorption at 660 and 940 nanometers to identify oxy and deoxyhemoglobin as part of the workings of the pulse oximeter. Now we are going to look into longer wavelength light, micrometer light, where CO2 is absorbed. Carbon dioxide preferentially absorbs light at 4.3 micrometers. That is 4,300 nanometers, high in the infrared spectrum. That is long wavelength light. Remember that different hemoglobin species absorb light in the hundreds of nanometers. To measure CO2 in clinical practice, we use light absorption, and it can be done in two ways. Taking a sample of gas and running it through a multi-wavelength analysis tool in the anesthetic machine, and that's known as side stream gas analysis, so you can measure nitrogen, oxygen, and volatile anesthetic agents and nitrous oxide. But more traditionally, there is a simpler approach, and that is to insert the monitoring device in line with the breathing system, and this is known as mainstream CO2 analysis. This is an example of a mainstream monitoring system. First, there is a transparent glass or plastic adapter that is inserted into the circuit between the endotracheal tube and the heat and moisture exchanger, and onto this is clipped the monitoring device. And this is how it works. The circuit adapter has little windows in the side through which infrared light can pass. Onto the adapter is clicked the major monitoring device that contains an infrared analyzer. Inside there is an infrared light emitter and a photodetector. The device is connected by a cable to the processing unit and monitor. When there is no carbon dioxide in the breathing system, the infrared light passes easily through the air into the photodetector and no information is passed to the monitor. During expiration, there is CO2 in the circuit. The infrared light absorbance is reduced and the photodetector measures the attenuated light. That quantity is converted into digital data and a value for expiratory CO2 is recorded. Due to the high sampling rates and processing, it is the maximum CO2 that is displayed. And of course, the maximum CO2 is the end tidal CO2. This is a very handy modern version of an old technology the Mainstream CO2 monitor, and it's plugged into the breathing system. It works on batteries, and there is a numerical display and sometimes a graphical one. It measures CO2 as it passes directly out of the circuit and generates a number for EtCO2. Once the breath has been delivered and the bag refills with expiratory gas, the capnometer displays a number. If the tube is in the airway, assuming that an adequate tidal volume has been delivered, that number should correlate reasonably well with the PaCO2. It's obviously lower. If the airway is supraglottic or the cuff ruptured or not inflated, the end tidal CO2 may be lower than expected due to gas leakage. Best of all, with these devices, the result is instantaneous. And that's the big value of mainstream analyzers. Every anesthesiologist will tell you that the standard side stream gas analysis device that we use in the operating room incurs a delay where time seems to stand still as one awaits the waveform display. If you only had one monitor, it would be expired CO2, and there are a lot of good reasons for this. The presence of end expiratory CO2 demonstrates airway adjacent positioning of the airway device or endotracheal tube, cellular metabolic activity and blood flow from the tissues to the pulmonary circulation, otherwise known as cardiac output. Remember, the cells make CO2 and the venous side of the circulation transports that CO2 to the lungs. Without blood flow, the CO2 doesn't arrive in the lungs. Gas exchange across the pulmonary capillary alveolar interface, and alveolar ventilation, that is moving gas in and out of the lungs, and finally it can be used for diagnosis of cardiopulmonary disease. Now, sometimes people ask me, is the saturation probe not good enough? Well, I will tell you this. If you put a tube in and don't measure CO2 and wait and see if the patient desaturates, you've made a gross error. The reason why is that pre-oxygenation prior to intubation is a very effective way of prolonging the non-hypoxic apnea duration. Unfortunately, it also gives false reassurance in the case of an esophageal intubation, and several minutes of non-ventilation may pass before the saturation starts to fall. The CO2 coming out of the tube arrives very quickly, and you know almost instantaneously that the tube is in the right place. If the partial pressure of end tidal CO2 is over 40 millimeters of mercury or 5.1 kilopascals, it is elevated. What does this indicate? You're in the operating room with Ralph. He's 54 and he's undergoing a robot-assisted prostatectomy. We are 45 minutes into surgery under general anesthesia with neuromuscular blockade, a remifentanil infusion, and an FiO2 of 30%. Tidal volume is 475, respiratory rate 12, and end tidal CO2 after intubation was 38 millimeters of mercury or 5 kilopascals. Over the past 30 minutes, the end tidal has risen to 50 millimeters of mercury or 6.6 kilopascals. What's going on here? End tidal CO2 can go up during anesthesia or in the ICU. When it happens during anesthesia, the problem is in one of three fields: pulmonary, metabolic, and flow and cardiac output. The main reason most patients have a rising end tidal CO2 is just due to hypoventilation, inadequate alveolar ventilation with respect to the amount of carbon dioxide produced. Occasionally, the patient may rebreathe carbon dioxide because the soda lime has worn out and the flow rates are too low. In this particular patient's case, the CO2 that was entering the body through the peritoneum was being absorbed and it was increasing the partial pressure of CO2 in blood, and as a consequence the end tidal was increasing. But the body can actively produce more CO2 than normal in certain circumstances, for example with malignant hyperthermia or during a thyroid crisis. The CO2 can also increase during the case due to better flow or perfusion, situations where the cardiac output may improve or venous return may improve, such as when we volume resuscitate the patient, or we put them on inotropes, or we give them vasopressors that restore the unstressed blood volume. But we also see it in situations where the circulation has been partially cut off. For example, a cross clamp put on during aortic surgery, or a tourniquet that was put on for lower limb surgery. When it's taken off, there is a big increase in flow back to the heart containing lots of CO2. And we also see that with patients coming off cardiopulmonary bypass. Again, in the ICU, the major cause of an increase in the CO2 is hypoventilation, but it also may be associated with progressive lung injury and an increase in the ratio of dead space to tidal volume. We see it when patients have started intravenous nutrition, where they start to generate more CO2 because of more metabolic activity, and where there is an increase in muscle activity associated with seizures, shivering, agitation, reversal of neuromuscular blockade, or rewarming after hypothermia, and again due to overall better blood flow associated with vasopressors, volume, and inotropes. The key point here is that the most common cause of a high end tidal CO2 is hypoventilation associated with low alveolar ventilation. This is either due to inadequate minute ventilation on mechanical ventilation. Remember, an increase in the tidal volume is far more effective than an increase in the respiratory rate, or inadequate spontaneous ventilation due to neuromuscular weakness or excessive sedation or anesthesia. Now let's move on to low end tidal CO2. You're in the operating room looking after James, who was undergoing knee arthroscopy under general anesthesia. He's given an opioid and propofol, an LMA is placed, and he is put on volatile anesthetic agents, and he starts to breathe spontaneously. His tidal volume is 230 mils 12 times per minute, and his end tidal CO2 is 25 millimeters of mercury, or 3.3 kilopascals. So in this situation, his end tidal is quite low. What's going on here? Looking back at the distribution of CO2 in the airway, there is a significant gradient between the alveoli and the upper airway. The anatomical dead space is 150 mils, so when James hypoventilates, he is mostly ventilating his dead space. Simultaneously, hypotension increases the dead space fraction, thus reducing CO2 removal from both tissues and the lungs. So James is producing lots of CO2, but he is hypoventilating, and you're not seeing that CO2 coming out of his body. He is given ephedrine to improve his blood pressure, but continues to hypoventilate. After 10 or 15 minutes, the CO2 buildup in his alveoli has increased markedly, and the end tidal begins to rise substantially. Eventually, the end tidal CO2 rises to 7 kilopascals, or 52 millimeters of mercury. You may or may not be alarmed, but I will tell you that with persistently low tidal volumes, this is a major underestimation of the true PaCO2. You put him on a ventilator, for example using pressure support ventilation, the tidal volumes are now 500 mils and the end tidal CO2 rises to 10 kilopascals, or 75 millimeters of mercury. This reflects the true alveolar CO2 level. It will drop fairly rapidly over the next 2 or 3 minutes. Low end tidal CO2 levels are again caused by pulmonary problems, metabolic problems, and flow problems. We do see this early after initiation of spontaneous ventilation, and anything that increases dead space, such as excess PEEP, auto PEEP, or a short I-to-E ratio, that's a very long inspiratory time, will cause an increase in dead space and a reduction in overall alveolar ventilation. In metabolic terms, patients may hyperventilate due to agitation, anxiety, or metabolic acidosis, or they may just not produce carbon dioxide because of hypothermia, particularly therapeutic hypothermia in a heavily sedated patient. And finally, the end-tidal CO2 may be very low due to low flow, due to hypovolemia, cardiogenic shock, or an obstructed circulation. Here is an example of such a situation. You're in the operating room and you're looking after Brenda, who's 55, and she's undergoing a total abdominal hysterectomy under general anesthesia. 1 hour into the case, her heart rate is 60, blood pressure 105/65. She's on volume control, 375, 12 breaths per minute, PEEP of 5, and FiO2 at 30%. Her saturation is 99%, end-tidal 40, which is 5 kPa. 5 minutes later, the end-tidal drops to 20 millimeters of mercury, or 2.6 kilopascals. What's going on? This is a cartoon of normal ventilation perfusion relationships. Each of these lung units is well perfused. Consequently, the end expiratory PCO2, the end-tidal CO2, is 38 millimeters of mercury, or 5 kilopascals. If blood clots travel from the legs or pelvis into the right side of the heart, they are propelled into the pulmonary arterial circulation. End arterioles will become plugged up and blood flow will stop through these units. The alveoli that they perfuse will become dead space, with the result that clearance of CO2 will be reduced with a corresponding fall in the end-tidal CO2. And that is what is happening to Brenda. She is suffering a pulmonary embolism. Subsequently, what happens next is quite interesting. Blood that can no longer flow to the plugged off parts of the lung redistributes to lower resistance channels, flooding some alveolar units with blood. The flow is so high that there is insufficient time and surface area for gas equalization, with the result that some lung units develop a low ventilation perfusion character, and the result is hypoxemia, often the first blood gas abnormality spotted in pulmonary embolism. The PaCO2 and the end-tidal CO2 may have normalized at that stage. The key point is that the most common cause of a low end-tidal CO2 is hyperventilation. That means excessive minute ventilation on mechanical ventilation or inadequate sedation or analgesia during spontaneous breathing. But don't forget that the patient may have metabolic acidosis. In metabolic acidosis, patients hyperventilate in direct proportion to the reduction in the strong ion difference or increased anion to cation ratio. It is always worth looking at the gap between the venous and the arterial PCO2. Normally, that is less than 6 millimeters of mercury, or 0.8 kilopascals, even in acute metabolic acidosis. If it is greater than that 6 millimeters of mercury, or 0.8 kilopascals, consider that the patient may be failing to compensate adequately or may have a hypoperfused state, for example, due to bleeding. I will cover the CO2 gap in a later tutorial. Finally, in this tutorial, I started with a discussion of carbon dioxide and discussed capnometry. But if you're a healthcare professional working in anesthesia and critical care, you may not be familiar with this technology. Capnometry refers to the measurement of carbon dioxide and end-tidal gas numerically quantified in partial pressure. Capnography refers to the graphical display of carbon dioxide tension in the breathing system throughout the respiratory cycle. While capnometry provides quantitative data and confirms airway access and ventilation, capnography is more useful, and in anesthesiology, it is the standard of care. Let's review this tutorial. In this tutorial, we discussed monitoring carbon dioxide, and I discussed carbon dioxide in expired gas. I went on to explain what end-tidal CO2 is, and we discussed capnometry, how it's performed, what it means, and what is the cause of a high or a low end tidal CO2. In the next tutorial, we're going to discuss monitoring carbon dioxide using a side stream gas analyzer, and we're going to look at capnography and how to identify abnormal capnographs. I'll see you soon, and I guarantee you'll learn something.